Great. Good evening, everybody. I hope you can hear me well. It's really nice to see you on an evening, and thank you very much for coming. I am going to tell you a little bit about the work that I do as a consultant neurologist. So I run the Oxford Headache Centre here. And we see all sorts of interesting headaches, some pretty beastly ones as well, I have to say. And we try to help as many people as we can. And sometimes we do, and sometimes we're struggling. But I think one of the things that's making life really interesting for people who are working in neurology is that the way in which we approach neurology, patients with neurological problems, is really changing, and I'm going to predict that it's going to be completely different in another 10 years' time. So anybody who's interested in sort of a career, now's a great time to join in. And that's partly because we've got tools now to be able to understand the brain that we just couldn't even dream of, maybe even 4 or 5 years ago. And that's opening up treatment options and ways of thinking about new cures for headaches and for other really disabling neurological conditions that, as I say, were never really dreamt of. So, headaches, if you don't suffer them, really, are quite easily dismissed. If I talk to my colleagues, if I talk to general practitioners, well, it's just a headache. Take a pill, life will be better. And that's a really popular conception. But of course, there are lots of people, and by lots I mean millions upon millions around the world, where it's more than just a headache, more than just a one-off. And these are individuals who might be getting several headaches a month, several headaches a week, maybe a continuous headache. And if you put all of those people together and you look and see how much they're using the NHS, for example, you start to realise just how much of a burden it is both for the patients, for the people who are suffering, as well as on the NHS. So 1 in 10 GP consultations, 1 in 10, you can think of all the things that you might go and see your GP for, okay, but 1 in 10 are for headaches. And they only refer, so the GP will only pass on to us maybe about 3-4% of what they see in headaches. And that translates into about 1 in 3 of the patients that we'll see in the neurology department as a specialist. Okay? And of course, lots of these patients end up going to accident emergency. That's from the NHS end. From the patient end, it's a really major cause of disability. Again, the commonest type of headache, which I'll come on to a little bit later, is migraine. And migraine's a really disabling headache because if any of you suffer it, you'll know that you end up having to go to bed very often, lie down or stop what you're doing. You feel sick with it. And so it's disabling. It's not just a headache, it's disabling. And if you add that up and look at the impact, it's actually worse than if you combine it with things like arthritis, diabetes, and epilepsy together. So it's a major, major disability. And that all leads to a really big impact on society. And again, that's quite underestimated. But we're talking about billions of money being lost because we're not able to manage patients well enough. Okay, so headache's a really important disorder, and that's one of the reasons why I study it and why I try to help patients. So, title was Beastly Headaches, and this was a rather interesting scan. It was reported in the Daily Mail a few years ago. And when you do a scan, this is an MRI scan, what you normally see is something like that. And you think, what could that be? So this man had a scan repeated several times, and it was really strange. This abnormality moved to there, to there, to there, to there. And this was really a very beastly headache because what it was a 6-inch worm removed from the man's brain, okay, causing this man's headache. Okay, that's a really unusual cause of headaches, all right? Don't be worried that this is something that you're going to get, okay? You know, once in a lifetime, perhaps we'll come across something like that, okay? So that's a genuinely beastly headaches. The more common types of headaches that people get are these, what we call the primary headaches. So that's this group round here. And actually in the community, the commonest type of headache is a tension headache, but those are usually pretty mild. Those aren't the ones that people go to their doctors with. They take a tablet over the counter and the headache goes away very often. The most common type of headache that people will suffer, even if you don't think it's that, even if your doctor doesn't think it's that, actually, the most likely type of headache that someone will have is a migraine. And we'll talk about that a little bit later on. Another type of headache that I'll mention a little bit later, and I mention it because it's horrendous. I mean, it's really, really bad. And it's called cluster headaches. And we recognize it relatively easily because it has a particular pattern. Okay, so 99 times out of 100, when someone's developing a headache that isn't going away, it's going to be one of these headache types. But what everybody worries about, of course, is that there is some more serious underlying cause, something malignant. And really, the number one worry is that could it be a brain tumour? The other things that people worry about, particularly if the headache comes on very suddenly, like a hammer blow, is that could it be an aneurysm? And you see these little sacs adjacent to the blood vessels of the brain. And what happens is that these sacs can rupture, causing bleeding, and it's that bleeding that then causes a devastating headache, suddenly out of nowhere, like a hammer blow, and these are pretty deadly. So very often patients may die immediately with one of those, and if they survive, they usually do very well, but it's getting past that first phase. Again, these are uncommon, but this is the thing that people worry about. So how worried should we be about that? And there have been some good studies to help us work out how worried we should be about that, because this is genuinely what GPs are worried about, and sometimes more than the patients themselves. And when you look at the figures, what you see actually is that your risk of having something serious like a brain tumour is really low. It's less than 1 in 1,000. Okay? So for the most part, if you're developing a headache and it's there for the first time, you're not going to have anything like a brain tumour that's causing it. You might have something serious, and I call it serious because it's a migraine headache, and that's probably something that's going to be disabling for you. But it's not going to be something like a brain tumour. And performing scans doesn't really help, and I'll go on to why. And this is the case if you've had a headache that's come on recently. If you've had a headache that's been going on for more than 6 months, the risks diminish to almost zero, back to the background risk of having a brain tumour, just if you randomly pick someone off the street. Okay? So I tell GPs that if you're seeing someone with a new headache, don't worry. It's really unlikely to be a brain tumour. Okay? So why is it that people get lots and lots of scans? I have to say it's because the GPs are so worried. Actually, when you do sort of audits of patients to see how reassured they are, they're a bit reassured, but then after about a year, actually they lose that reassurance. So it's not that helpful. And actually the problem with doing scans is that you pick up other things. And that's fine if the other things are things that you really should be treating, but a lot of the time you pick up other things that actually you have to shrug and say, I don't know what that is, or I don't know how we should treat it, or even worse, I think we have to treat it, but then you might get a problem because of the treatment. Okay, so scans are not always a good idea, and a part of my job is trying to reassure patients that they don't have a brain tumour, and actually a scan's not in their best interest. Okay, now this is something else that I really want to try and tell as many people as possible. It's really not well understood by my colleagues either. And this is the idea that actually painkillers, and it could be any painkiller including paracetamol, can become a double-edged sword. Okay? It is very instinctive that if you've got pain, you're going to reach for something to try to help with that pain. And certainly to begin with, taking painkillers will help your headaches. The problem is that if you keep on taking them and taking a lot of them, they start to become part of the problem. And they do two things. One is they cause a rebound headache. So they get rid of the headache for a bit, but the headache then bounces back. And the second problem is that they make the headaches resistant to the proper treatments. So we end up in a place where we're really desperately trying to get the patients better, but because they're taking too much of painkillers, those treatments aren't working. Now this is really hard because trying to get patients off the medications, what will usually happen is that the pain will get a lot worse for about a week or so before it then settles down. But if you can get through that first phase, usually things are a little bit better. And it's something interesting about medication overuse is that it's not just because people take painkillers. So it's not that painkillers are actually the root problem of the headache. It seems to really affect those who have an underlying susceptibility to the headache. So these are individuals that either have migraine or tension type headache anyway. And so it's those individuals who then take these painkillers and have been using them for some time that they get into this pattern. And my suggested treatment for this is to go cold turkey. And that is probably the best way of getting through. People have tried all sorts of different strategies, but ultimately, the best thing to do is probably to stop all of the medications, being aware, and I have to tell my patients this, that life will be pretty miserable for the first week. But then after that, things do get better. And actually, there was an interesting study in Denmark where they looked at patients who were getting headaches every day. So there was not a single day that they were not getting a headache. And they've been getting that for 3-4 years, have tried all sorts of treatments. And in those individuals, they just stopped all of their medicines. And unbelievably, 6 out of 10 of them got significantly better. Okay? Now, I'm not saying that that's going to happen to everybody who comes off. Clearly it doesn't, because it only happened to 60%. But it tells you just how much drugs, like painkillers, can actually lead to a dysfunctional system in your body. Okay? And sometimes you need to work with that and understand that to get better. That's a really beastly headache. Right, so this is the headache that I mentioned before, cluster headaches. It's also called suicide headaches. And that's because the pain is so severe, excruciatingly painful, localized around the eye. And the way that I recognize it is because I see patients with migraine, what they like to do with their headaches is they like to go and lie down and keep still. The patient with the cluster headaches can't keep still. They are literally banging their heads against a brick wall. Okay? Because the pain is so severe, they're agitated with it. The other key feature of cluster headache is that very often the eyes will become bloodshot, or it will start tearing on the side that they're getting the pain, or the nose will get blocked, or the nose will run. And so that picture is very characteristic, and we see that. It's called cluster headaches because for many patients it tends to occur in seasons, so that you'll get a series of attacks, for example in the spring or in the autumn, and then other times of the year it'll be free. And so there's this pattern through the year. It also tends to occur almost at a particular time every day, very often early in the morning, and lasts for a particular duration of time. And so it's very, very characteristic. And with cluster headaches, you really need to know what the right treatment is, because the usual types of painkillers do not work. And unfortunately, that's also not really well recognized. And so we rely upon the patients who have this to really be the experts and tell the doctors, if they have to go to A&E, what they should be treated with. Because very often if you go to A&E, you'll get exactly the wrong treatment. You'll probably get something like codeine or tramadol. That won't work for cluster, and actually for migraine and for other tension type headaches, it'll give you medication overuse, before you can even blink. So exactly the wrong treatment. With cluster headaches, the treatment that we use to abort it is an injection of a triptan, something called sumatriptan. And it seems either it's only an injection or a nasal spray that will actually do the trick. A lot of patients also find that taking in oxygen really helps as well. Okay, so that's another type of treatment that can work. That's cluster headaches or suicide headaches. Right, so let me turn to migraine. And migraine is really a major area of my research. And I find it fascinating sort of on a number of reasons. Firstly, because of the clinical features of migraine, actually also the history. Migraine's been mentioned back to prehistoric times. You've got writings in the sort of Egyptian hieroglyphics and the Ebers papyrus, which describe some early treatments. Even Hippocrates described a bilious headache, which was probably migraine. So there's a rich history. And early on, people used to think that there were demons or ill vapors that you would have to release in order to be able to treat migraine headache. The pain of migraine is pretty characteristic, and very often the pain will be on one side or the other. It might be throbbing. It will be pretty severe. Doesn't always have to be though, and different people have different thresholds. So for some people it might be completely incapacitating, and for others it's bad, but they kind of be able to carry on. And it's associated with feeling sick, light sensitivity, sound sensitivity. Some people find strong smells difficult, and so on. Now, that's the characteristic. But again, very often, patients won't have this full sort of spectrum of things, and they'll have a few. But it'll still be migraine. And again, what I tell my colleagues, general practitioners, is really, if someone's come to you with a headache and they've sought you out because of the headache, it must be impacting them. Most likely it's a migraine. About 1 in 3 people who have migraine get something called an aura. And the aura are neurological symptoms that occur just before the headache itself. Okay, that's typical. Sometimes you can just get those neurological symptoms on its own and you don't get any headache at all. So we recognize that too. And the aura very often are things like visual symptoms, hallucinations, patterns, colours. And for some people, they'll describe that it will spread across their visual field. Or if they've got, for example, pins and needles, that's another neurological symptom that we hear about in people who get migraine, that it will start in one part of the body, for example, in the face, and then slowly work its way down. And that's very characteristic of a migraine aura. So when you look at the full evolution of a migraine, it's more than just a headache. People get premonitory symptoms. They may become irritable, they may get cravings, start yawning, and then they may get the aura, about 1 in 3. Then you've got the headache, but then even after the headache's gone away, things might still not have resolved. And so you can begin to see that the headache is really just only one part of the reason why migraines can be disabling. And we're increasingly recognizing the fact that we can see, all of these type of complexity of symptoms. Okay, so this is the migraine aura, and people have been thinking about what causes the migraine aura for a little while. Because it can affect your vision, it can affect sensory symptoms. Some people can get paralysis, you can get speech disturbance, all sorts of neurological symptoms. In fact, in some cases, you can confuse it for a stroke, a mini stroke, and that can be quite alarming. But as I said, one of the key features is that for some patients, the symptoms spread, and you can map out how quickly that spreads. And that's given us a clue as to what we think is causing migraine aura. And this was worked out some decades ago, but more recently has been more evidence has been found using modern brain imaging studies. So this was a study that was published a little while ago now, actually, about 16 years ago. And this was somebody, if I'm remembering rightly, they had their migraine provoked if they played basketball. So this gentleman was involved in this study, and they got him to run up and down with a basketball as fast as he could. And then he said, yeah, it's coming on. And they rushed him into the scanner, and they were watching, and they were seeing which part of the brain was being activated as he was developing his migraine aura. And what was really interesting was that the part of the brain that's involved in vision, which is the back of the head, you started to see changes in activity, and that then slowly spread at the same rate at which there was the movement of that visual aura. So this, for most people, has become convincing evidence that this phenomena, these cortical waves that we call cortical spreading depression, is the underlying basis of that aura. Okay, so that's aura. What about the headache? Well, you probably think, most people think, that the headache comes from the blood vessels. And that kind of makes a lot of sense, especially because the headache is a throbbing headache. So you can kind of imagine blood vessels kind of pounding away, and that's what's giving you the headache. And that also made sense because in the 1950s, when people were operating for patients who had head injuries, for example, or other procedures, back then, surgeons would go and poke a brain and see, well, does that hurt? Does that hurt? Does that hurt? Okay, probably couldn't do that now, but we learned a lot with those simple studies back then. And what they realized was that the brain itself didn't have any feeling. But what was really innovated was the lining of the brain and the blood vessels. And it's innovated by by some pain nerves called the trigeminal nervous system. And these trigeminal nerves supply the entire head, the face, and it carries all of the sensory information. And so that system of supply to the blood vessels from the trigeminal nerve is called the trigeminal vascular system. And in the 90s, they realized that if you activate this nervous system, what happens is that the nerves release inflammatory molecules. And those inflammatory molecules sensitize the nerves further. So it becomes like a little loop. And so you get this state, is what was argued, that the nerves are activated and they're inflamed. And so that's really was what people were thinking the migraine headache was about. But the debate still goes on, because headache's pretty unusual, isn't it? Because if you think about pain, you feel pain if you have an injury somewhere. You know, you whack your finger, you're going to feel pain. So who's whacking your head to make you feel pain? Okay, that's a mystery which, you know, we still don't really know. Why is it that that pain is occurring? And there's a division really in the field. Some people think, just as I've explained now, that it's all coming from the periphery, just like whacking your finger. It's something about the blood vessels, it's something about the lining of the brain that's wrong, maybe it's inflamed, and that's then driving the pain sensation and making people feel that they've got a headache. There's another strong group, however, who believe that actually the pain is all generated inside the brain itself. So it's not that there's any pain nerves there, but there's a center, and it's generating signals, and those signals, for whatever reason, are being interpreted as pain. It's been called the migraine generator. And there's a big division in the field as to which is which, and I don't think there's any clear answer to what that is. But there was one interesting study which might suggest where migraine is coming from. And again, this is another heroic study. I mean, I don't know where we would be without people volunteering to do absolutely amazing things in order for us to be able to learn about headache. This was a study that was done in Germany. Somebody who was getting recurrent migraine attacks, and they went into a scanner every day for 30 days. And they were not allowed, or they chose not to, they were asked not to take any painkillers. And so this patient was then, the research group that undertook this study was able to see the brain activity every single day, all the way through the month, both before the headache started, just as the headache was building up, and then after the headache resolved. What was even worse, by the way, for this patient was that just by doing a scan, you can't actually see anything. You need to see places being activated, and so you need to give some kind of stimulus. And ideally, if you're wanting to look at pain networks, you need to give something that's a painful stimulus. So not only was this patient having headaches and not being allowed treatment, they also had ammonia squirted into their nose. Okay, so that's a really noxious stimulus. And so when they did that, it was some really interesting findings. Because in this phase, before the headache even started, so before the pain was switched on, the place that lit up was a part of the brain called the hypothalamus. So that's really deep in the middle of the brain. Okay? And so that perhaps supports the idea that there is this migraine generator, and that's where the pain is coming from. There isn't a peripheral injury. It's being generated by a structure like the hypothalamus. And that's then switching on all of the other pain systems. And so that's really interesting, and that's given us a lot of clues as to where to think about and what to do when thinking about where migraine is coming from. Okay, so that's the pain. What about the question as to why is it I get headaches, but the person next to me doesn't? Okay, and that's a really big, broad question. Why is it some person gets cancer? Why is it a person gets dementia? And in general, it boils down to two factors. One is the genes that you inherit, the genes that you have, and not just genes on their own, but the combination of genes. Okay, that's one really important factor. And the reason genes are so important is because the genes are the coding instructions for the way in which our body is built. So they tell our nerves how they should be firing, what their setting is. Okay? But on top of that, of course, is the environment. Because we know that if you take two identical twins, that one twin may get headaches and the other twin won't. So they've got exactly the same DNA, but there's something different. And that thing that might be different is the environment to which they're exposed to. And so in general, and this is not just headaches, diseases arise because of your genes and the environment and the interaction between those two. This is the kind of things that we recognize in the migraine environment. And again, if you suffer migraine, you'll know that there's lots and lots of factors, and very often it's different for different people. But common kind of themes are lack of sleep, hormones, stress. Okay? Those are very common factors that predispose you to getting migraine. Now, when we're thinking about the genes then, if we turn away from the environment to the genes, we think of the genetic causes of disease. We can divide them, broadly speaking, into those disorders where all you need is a single gene that's abnormal. The effect is so disastrous on your system that that single gene out of the 30,000 genes that you have is sufficient to give you a particular problem like migraine. And we call those monogenic disorders, a single gene. That accounts for a teeny tiny proportion of migraine. Okay? The vast majority of migraine, and the vast majority of most diseases, are not due to a single disastrous mutation, but lots and lots of changes in your genes all coming together. And I'm talking, maybe even as many as 30,000 different genetic variations that are unique to you And it just swings your risk just a little bit, but just enough that with the right environment, you come out with a particular disease. Okay? And we call those polygenic disorders. Those are the much more common type of disorders. And we have different ways of being able to identify one type of gene, the monogenic forms of the disease, and the polygenic forms of the disease. Okay. So migraine has a very clear genetic basis, and we know that from things like twin studies. And so we can estimate that if you look at everybody who's got migraine, about 50% of the reason that people get migraines is due to their genes. Okay? And we know that particularly from twin studies. But one of the things that's really interesting for me about studying migraine is that there's a spectrum. And so just like I told you that there is monogenic disease and polygenic disease, you see exactly the same thing in migraine. And so there's a form of migraine called familial hemiplegic migraine, where patients get the headache, but if you remember, I mentioned that a lot of patients also get the aura. And in this case, the aura is paralysis down one side of the body. So again, quite a severe form of headache. And because this is a single gene mutation, those are, relatively speaking, easier to pinpoint. So when we looked at that, or not myself, but my other research colleagues were investigating this, they found a certain set of genes that were abnormal. And to tell you what those genes were and what it means, I need to tell you a little bit about nerves. So the nerves are the electrics of our body. They're our communications. They're the reason that we think. And the key property of the nerve is that they're excitable. And that's how they send their signals from one part of the body, and sometimes that can be as far as from the head all the way to the bottom of the spinal cord, or from the spinal cord all the way down to your big toe. And so they can be, 1.5 meters long if you're particularly tall. Okay, so they have to be able to communicate fast, and they need to be able to communicate robustly. And that ability to be excitable is dependent a lot upon the ability for various salts to get in and out of those neurons. And that's very tightly controlled. And it's tightly controlled by a set of proteins called ion channels. And these ion channels, you can think of them as pores that are sitting on the membrane of all of these nerve cells, and they allow things in and they allow things out, like sodium and potassium. And it's those salts that help determine how excitable a nerve is, and are also important for generating another feature of the neuron, which is this signal that they send called an action potential. Okay? So that's all a bit complicated. The main thing that you need to remember is that ion channels are really important in governing nerve function. And so when people started to pick out the genes that were causing this hemiplegic migraine, what they found was that the genes that were being mutated were genes that were ion channels. So these were all genes that were essentially making the nerves hyperexcitable. They were much more likely to fire. They were much more likely to send their signals. And so that gave more weight to the concept that migraine was not really a blood vessel disorder at all, but that actually it was a nerve disorder. Yeah? So a disorder of nerves and nerves becoming hyperexcitable. So you can imagine that if your pain nerves are hyperexcitable, hyper-responsive, then maybe with the right environment, that's why you're predisposed to getting headaches. So it kind of makes sense. Okay. So that's an unusual form of migraine, and that's pretty rare. What about more common types of migraine? Well, that's been tough. It's really hard to find genes when it's not a single devastating mutation. But occasionally you come across families where you see the migraine go from one generation to the next. You know it's not a single gene mutation, but maybe you might find something if you look hard enough. And we found a family like that in Canada. Lots of generations, a particular form of migraine. In this case, it was a migraine that was just a normal migraine, not one of these unusual hemiplegic migraines. And this, again, very interestingly, was a mutation in an ion channel gene. And this particular ion channel gene is called TRESK, and this lets through potassium into neurons. And we think that this alters the excitability again of those nerves, again making those nerves hyperexcitable. If you have migraine, are you likely to have a TRESK mutation? Again, I'm afraid the answer is almost certainly not. Because, again, although this is a very common form of migraine, the mutation itself is extremely rare. We hardly ever find it. But this is giving us insight into what's causing migraine. Again, it's building upon the previous studies that's telling us that migraine is a disorder of nerve excitability. Okay? And then we're left with common migraine, where, again, we're now thinking of lots and lots of different genes coming together, all acting just to very marginally shift your risk. And there are studies now being done on lots and lots of patients to be able to pick out some of these regions that might be contributing to the risk in the gene. You need to examine 100,000 patients and compare them against 100,000 people who don't get headache. And so these type of studies are starting to be done, and the genes are starting to be revealed, but at the moment, it's not making much sense, to be honest. And so more work needs to be done in that area. All right. What about treatments for migraine? Where are we with treatments? So the gold standard treatment for bringing about an end to a migraine headache are the triptans. These were discovered 20, 30 years ago, and I think they were revolutionary, because for people who were suffering with migraines and were just not able to function, these were able to abort their migraine attacks. And it's these same triptans that are actually also effective in cluster headaches. Now, those abortive therapies are fine if you're getting headache once in a while. But even triptans, if you take too much of them, will give you that other beastly headache that I told you about, which is the medication overuse headache. So if you're getting lots of headaches, what you need to be on is a migraine preventative. And so that's drugs like topiramate. And these drugs are not painkillers, but what they try to do is they try to reset your brain chemistry. They try to reduce that hyperexcitability of your nerves. Or at least that's how we think that they work. A more recent treatment for migraine that's really looking great, actually, for people who get really bad, frequent migraines, which we call chronic migraines, is Botox. So I don't know how many of you are familiar with that, but obviously you'll know of it for cosmetic purposes, but it turned out that if you give it in a particular way, that actually it makes migraine better. How on earth would that work? Actually, nobody really knows. It's not because it's reducing muscle tension, and we know that because in research, if you give a form of Botox which doesn't cause paralysis, it still works. So it's not the paralytic effect. And some people think what's happening is that the sensory nerves around the head are taking up the toxin, and that's then traveling back to the relays in the brain and altering the way in which pain signals are getting through. Don't know whether that's true or not. I guess that's the subject of further research. So that's Botox therapy. But there's real excitement in the air at the moment for migraine and for cluster headache, because there was a molecule that was discovered. Actually, it was discovered quite a while ago, but it was a molecule that looked as if it was very, very important for the development of both migraine and cluster headache, and this molecule called CGRP. And do you remember I said that when the trigeminal nerve, the pain nerves are activated, they release inflammatory molecules? Well, CGRP is one of those inflammatory molecules. And it's released in the lining of the brain, it's released around the blood vessels. And it then acts to sensitize the nerves. It probably also acts in other ways as well that we're again just beginning to discover. And what a number of companies have been doing has been to develop therapeutics that target that molecule. And the first type of therapeutic was a conventional drug. And what it did was to block the receptor for CGRP, the thing that CGRP bound to. And it looked great, but then it was pulled because it caused liver toxicity, it caused liver side effects for a small number of people. And that was a shame, because it really looked as if it was quite effective. So then, drug companies started developing something really novel and interesting, which was to use antibodies. I never thought I would see antibody treatment for headaches. So antibodies are things that we have in our system that's part of our immune system and protects us. And antibodies are characterized by the fact that they can bind to things, latch onto things really well. So they might latch onto the surface of bacteria, for example. And that's how they can survey and get rid of those nasties. And what drug companies have used here is the antibodies to latch onto the CGRP and then to mop it up. And so that's the treatment that's now being put forward in clinical trials, and those are the trials that we are literally about to start next week for cluster headaches, and hopefully in about a month or two for migraine. So if you're interested, please do get in touch. We're looking for volunteers for that. And the idea behind it really is that it's thought that both in migraine and cluster headaches, the amount of CGRP that you have is increased. And if you have the antibody, it will mop that CGRP up. There is an antibody that also binds directly to the receptor of CGRP, and both seem to work in a similar way. And the clinical trials so far look promising. And what you can see, so when you do a clinical trial, what you normally do is you give somebody a sugar pill or something that isn't the drug or the therapeutic, and you compare it against your test drug, the thing that you're developing. And actually in all pain studies, in all headache studies, you probably heard about this, you get a really strong placebo response. Okay, so even if you don't give anything, people get better. It's amazing. I mean, I wish we could harness this all the time. You know, it would save a lot of money, wouldn't it? So people get better all the time. So you need to design the clinical trials really carefully. And that's why you always give one group that placebo and the other group the active arm, and you're then looking for a difference. And what's been really nice so far in the studies that have been published is that you see a clear difference between the treatment and the placebo. So I think this is looking really promising. And the trials that we're undertaking now are for patients who really not responded to other therapies. Okay, so we're looking to see whether or not this antibody is also effective in what we would call a more resistant population, because that's where the need is. Okay, so those are the trials. Okay, so I'm going to finish my last section talking about what I do, I would say probably for 80% of my time, which is not working in the clinic, but doing basic laboratory research. And that's what I'm trying to do, is I'm trying to find more effective, safer drugs. A really frustrating thing that I have in clinic when I'm prescribing patients a migraine preventative is the side effects of the drugs that they have. For example, topiramate, NICE, the body that sort of vets what treatments to give to what people, that's the first line suggestion. They say everybody should get topiramate. Topiramate is a great drug. It works on migraine. It really does reduce it. The problem is, some people, they find that their thinking becomes slow, they can't find the right words. And you can imagine migraine, something that tends to affect people from 20 to 50 very often. That's the kind of peak prevalence. That's when you need to be at your peak productivity. The last thing that they want is for a medicine that's going to cognitively slow them down. So those kind of side effects make my job a bit frustrating. So I'm constantly thinking about how do I find ways of getting better treatments. So what we do in Oxford is we combine all of that genetics, the genetic studies that we've been talking about, with imaging of patients so that we understand what's happening in their brains. And then we try to think about, well, can we reproduce that in a dish? Can we make something that resembles a migraine and then use that to try and find new drugs? But how do you get at patient nerves? Because if you want to study headache, if you want to study pain disorders, if you want to study Alzheimer's, in fact, you need to be able to get patient nerves. So how do you do that? How many of you are going to volunteer to let me open up your brain right now and take some nerves out? Nobody? No? Oh, disappointing. Okay, not surprising, perhaps. Okay, but there was a miraculous discovery, and it was now about 10 years ago, that's given us the ability to be able to get at patients' nerves. You'll all know that we start off life from a single fertilized egg, and that single egg, that single cell, will divide and divide and divide and divide and divide to become 1 trillion cells. And it'll become different. You'll have hair cells, you'll have liver cells, heart cells, nerve cells. So all from that single cell. What if you could reverse that? Well, that's the incredible thing, you can. And it's called reprogramming to get to something called stem cells. So now you can take a skin sample, you can take a blood sample, you can take a hair sample, any adult cell from any of you. I mean, this is almost science fiction, isn't it? Where I can take something from you, and it doesn't need to be very much, and I can turn that cell, turn the clock back. This is, aging cured, okay? At least for the cell, if not for you. And I can turn it into a stem cell. And that stem cell has that ability to multiply and multiply and multiply as many times as it wants, so it's effectively immortal, and it can become any cell type in the body. So I can then put on a cocktail and make that stem cell that I've just generated into a nerve cell. So at last, I'm able to generate what might be, or maybe I can, a headache in a dish. Okay? Because I can get those nerve cells growing in my dish. So how do I then think about studying headache that way? Well, the trick is to get those skin cells or those blood samples from patients who suffer headache. Turn it into a stem cell, and then from the stem cell, turn it into those pain nerves that you can see there. And so then I've got not just any nerves, but I've got the nerves from people who are suffering with headache. And I can then look and see what kind of abnormalities there might be in those nerve cells compared to somebody who doesn't have headache. And so that's the kind of thing that we're doing. And we've got tools to be able to look at the activity of those nerves, and we can see them firing away like this, when really that's not what they should be doing. So we can see that these nerves from patients are indeed hyper-excitable. They're firing away. And we can do things like add drugs that we use for migraine treatment, like propranolol or amitriptyline. And we can see that actually that helps settle those nerves down. So we've now got the tools to be able to start to investigate what's happening to people's nerves and how to get them better, all in a dish. The other thing that we can do is not just look at the genetics, which is really what that last slide was about. We can also see what happens with the environment. We can put on hormones. We can add inflammatory soup. And so this is a healthy person's nerves. This is the nerves from someone who gets bad headaches. And you can see the striking difference in response when you add something that stimulates the inflammation. And so you can see why, perhaps, people who have got headache disorders are more susceptible to the external environment. Okay? So these are really powerful tools that we're using in order to try and find better drugs. And so the essential concept, and this is almost my last slide, I think, is that we take those abnormalities that we've seen in the dish, our headache in a dish, the hyperexcitable nerves, and we can then screen new compounds, new therapies. And what we're trying to do is to convert the nerves from looking like this into something that might look like that. And that might then be the therapy for tomorrow. These are really exciting times for us. It's a great time to be in research. It's a great time to be a clinician, because I think there are things that are on the horizon that were just not imaginable, even not that long ago. And so if you do suffer with headaches and you found that treatments are really not working for you, don't lose hope, because there are clinical trials ongoing at the moment which will result in therapies very nearby. And in the longer term, there are likely to be better therapies than could have ever been imagined. So I'll stop there and just summarise by saying that headaches can be really disabling and quite beastly. There are effective treatments for a lot of these, but you need to get the right diagnosis, and that's often a first step. Another really important step is not to take too much painkillers. We're conducting trials on some of the next generation therapies already. Please do get in touch. And we're undertaking research looking even further in the future. Thank you very much.